everyone can, first I want to just check to see that everyone can hear me. Ben, am I coming through all right?
Yes, that's much better.
Yes, we can.
Okay, great. Okay. Perfect. Then we will go ahead and start, as it is actually right on the hour, and we want to make sure that we take advantage of the time that we have. And we already have a good group on the line, so I thank everyone for joining on time. First, welcome to the webinar that we have today on protecting, promoting, and supporting IYCF during the COVID-19 pandemic, with reflections and recommendations. This is a webinar that's being brought to you by Save the Children, Johns Hopkins Centre for Humanitarian Health, SafelyFed Canada, and UNICEF, with the support from the IFE Core Group, the Technical Rapid Response Team, and the GTAM. With that, I want to just mention first that we will be recording the webinar today, so that you know, and that others can benefit from it at a later date that aren't able to join today. If everyone that's not a presenter can turn off their videos, that would be much appreciated, as well as your audio, your microphones. If you can't find them, go to the bottom left-hand side of your screen. There'll be a microphone where you can mute yourself and a video button where you can stop the video. If you're on a tablet, they might be slightly in a different location, but more or less it will be on the bottom bar. I know a lot of people already have done it, but if you haven't already, please introduce yourselves in the chat box. If you can tell who you are, your organization, if you have one, and what country you're coming to us from today, that would be greatly appreciated. During the presentation today, if you can type any of your questions or comments or input into the chat box, that would be wonderful, so that at the end we can go through that, but I'll tell you more in a minute. And finally, after the webinar, there will be a short evaluation. It takes an average of 6 minutes. So please do use that link to give us feedback. It helps us make our webinars better in the future. So we appreciate you taking that extra time at the end. Okay. Next slide, please. Okay, so today, first, as I've already just done, the introduction, and please and welcome. Thank you all for joining us. Today's webinar, we have an hour and a half, and we like to keep with time. So what we will be going through today is, first we have an overview of the evidence and recommendations. That will be followed by communicating about breastfeeding during the COVID-19 pandemic, the do's and the don'ts. At the moment, there's a lot unknown out there, and so trying to make it so that everyone can program the best they can given what we know at this precise moment. That will be followed by some suggestions for IYCF programming. Sorry, I've already broken a golden rule of turning off my volume. There we go, off you go. So all presenters, if you haven't, please turn off your phone volumes. So suggestions for IYCF program adaptation during the COVID pandemic. So some scenarios and potential adaptations. That will be followed by a Q&A session. The Q&A session, we would like to have as rich and in-depth as possible, as much time as possible. So we're going to try to make sure that everyone keeps the time on the presentations. So with that note, I'm going to go to the next slide, please. Okay, so the objectives of today's webinar, I think we all know we're all here because we have a situation that's been going on worldwide, a pandemic for the coronavirus 19. And today what we want to look at is an overview of the latest global and evidence-based recommendations related to infant and young child feeding and COVID-19, so that we have a better idea on how we can adapt to programming. We're going to outline suggestions and reflections around communication about breastfeeding for healthcare providers and caregivers, as well as adaptations for programs in the context of COVID-19. We know with infant and young child feeding programs, whether it's infant and young child feeding or infant and young child feeding in emergencies, both of them, they require lots of contact, usually with mothers and babies. Therefore, we are here to try to see how we can help you adapt your programs to the current situation. Next slide, please. Okay, so to present everyone who's going to be speaking on the call today, the webinar, first I'll start with myself, and then I'm going to hand over to my colleagues that you should see in the video right now. I am Andy Kendall. I'm the Program Director for the Technical Rapid Response Team, otherwise known as the Tech RRT. Over to you, Maya.
Hi, I'm Maya Ververs. I am Senior Associate for the Department of International Health at Johns Hopkins, the Center for Humanitarian Health, and I also work for CDC in the USA.
Hello, everyone. This is Ashima Garg. A lot of you may have known me in different capacities. I work with UNICEF Program Division right now as nutrition specialist supporting infant and young child feeding programs. Thank you.
Good morning. My name is Michelle Pensabranco. I am the co-founder of SafelyFed Canada and the clinical lead for our projects.
Hello, I'm Jodine Chase, and I am also co-founder of SafelyFed Canada. I'm the communications lead.
Hi, this is Alex. Hello, can you hear me?
Yep.
I'm the global advisor for infant and young child feeding in emergencies for Save the Children, not just UK, all the members and the country offices. Thanks.
Hello, everyone. This is Linda Shakir Berbari. I'm here in my capacity as the IFE Core Group facilitator with the Emergency Nutrition Network.
Wonderful. Thank you all for presenting yourselves. Now can we go to the next slide? Okay, I'm going to hand over to our first presentation by Maya Ververs, and over to you, Maya.
Okay, thank you. Welcome, everybody. I'm very excited that you're all there. So I will talk a bit more about infant feeding and pediatric cases in general and COVID-19. Next slide, please. So this session, I will discuss what does the science tell us and what are some of the recommendations at the moment going around. Now, I have to give you here a disclaimer. All what I found and looked at is only up to date until a few days ago, 4th of April. As you know, there's a lot of evolving world we are also in science. And I designed this session for a global audience, not a domestic audience. Okay, next slide. So just to show you a map we have produced at the Johns Hopkins School. This is an overview, and this is from yesterday, a couple of hours ago. So the numbers are, again, sadly only higher. But I just wanted you to know that this map exists, and it's updated every few hours, so you can follow the response, sorry, the outbreak. Next slide. So the transmission, we have to, if we talk about transmission, and we talk a lot about it at the moment, you can see that you have to identify that some of the infective materials are either the droplets or droplet nuclei, what they say. And that depends on the size of the substance. So maybe next slide. If you have the COVID, it is droplet particles that is either in the air or in fluid. So if you have a bigger diameter, it's a respiratory droplet. And you will probably, what we know now is that the virus will probably be transmitted through respiratory droplets, most of all, and contact routes. And that means that when you're in close contact with somebody who has those symptoms, the respiratory symptoms like coughing or sneezing, and those droplets then can enter via your body, via mouth or nose or the eyes. It's also possible that you transmit the COVID through objects, can be clothes, utensils, toys, doorknobs, etc. And that if those objects are then close to you, you touch them. So either you touch the infected person yourself or the surfaces that that infected person has touched. And then you can be also, that virus can be transmitted. Next slide.
Maya, I'm going to interrupt you just for 1 second. We have lots of people with videos on. I would like to ask you to turn them off so that everyone can really see well the presentation for those who have poor connections. So in the bottom left, you should be able to turn off your videos. All of it, everyone except for the presenter, please. Thank you.
Okay, so there are also droplet nuclei, what we know that the virus can be transmitted through. These very small droplet nuclei can remain in the air for long periods of time, and they can be transmitted over distances than bigger than 1 meter. So in the context of COVID, we know that airborne transmission is possible, but mostly more in clinical settings.
The host has
So
again,
yeah,
I'm going
Andy,
to
go ahead.
ask people to please mute your microphones as well. We can do it ourselves, but it interrupts a little bit with trying to manage the slides. So if everyone can really try to keep yourselves on mute, bottom left of your screen, that would be much appreciated. Thank you. And videos too.
So the airborne transmission is possibly much more in a clinical setting where people are moving intubators or ventilators. But I must say the last word has not been said about this. There are further studies are needed to determine whether it's possible to detect the virus also in air samples from patient rooms and also beyond. But for the moment, it's probably mostly it's the respiratory droplet transmission. Next, please. So let's look at children, how children are affected and adults. So at the moment that we know is that the COVID infection is mostly characterized by a massive inflammatory response. We call it the cytokine storm. It's a substance that we have in our body that we normally use for a normal immune response, but it goes sort of in overdrive, and that causes respiratory distress. It's a lot in the lungs are happening and also organ dysfunction. So the inflammatory response in adults and children is different, and also varies in over time in your age. The older you are, the more you have this massive inflammatory response. That's why elderly are so much affected. This inflammatory response is less probably in children. Now, the reasons for that, there are many different reasons possible, but maybe some of the children are less exposed, but also because children and young children have a relatively immature immune response. So that might help in this case, unlike a lot of flu, of the influenzas, where you have children, young children and elderly affected, a U-shape. That is not apparently the case with COVID. It's not a U-shape. It's not that the elderly and the infants or the young ones are affected. It's more the infants in this case, or the young children are potentially protected. So in China, I looked at the data, and there was one research article at 72,000 cases and more, and only 1% was under 10 years. So it doesn't affect a lot of the children. Next slide, please. So there's a lot of research going on. I just looked at the WHO site. There are about 781 trials on COVID at the moment ongoing. But a lot of the research is on treatment and on vaccines, which makes sense possibly at the moment. Next slide. So what do we know with regard to children and how they are affected? Now, we must say in general, many people are asymptomatic or pre-symptomatic, but they can still transmit the disease, including children. One study I found, and I sourced in this presentation all my research articles, so you can look if you want to. In one study, they found that 13% of the confirmed COVID children were asymptomatic. But children in general are mostly asymptomatic, mild or have moderate symptoms. Now, I also looked what is known about the case fatality rate. So those that have it, how many die. Now, from the studies in China, we saw that 0.2% under 40 years died who had the disease. And in studies in USA, we know that in the group from 0 to 54 years, 1% died. So again, it is affecting mostly older people. There was one study in China with over 2,000 children, and they looked at confirmed and suspected cases. And this article has produced quite a lot of media row, and also amongst us practitioners and scientists, because it stated that young children, particularly infants, were vulnerable to COVID-19. The problem was, and they said also the proportion of the severe and critical cases was 11% was under 1 year. The problem was that though we don't know who was serious or critical, whether they were suspected or confirmed cases. So these serious cases or critical cases could have been well affected with other respiratory diseases, not COVID-19. So we think that this study might need a relook. Next, please. So there are a lot of controversies now. Is there a need for temporary separation of mothers, whether they suspected confirmed cases with COVID and a newborn? And is breastfeeding transmitting the virus to the infant? Yes, maybe, or no. Next. So from all the studies, we know that the amniotic fluid has been negative, so that mothers who had it or umbilical cord blood, or they were all negative for the virus. So it looks like there is no intrauterine infection caused by vertical transmission in women who have developed COVID in a late pregnancy. Now the virus is present, has been in feces, but we don't know whether that actually is transmitting the virus, the disease itself. Next. Now, in a recent paper from the JAMA, pediatrics, there were 33 neonates of COVID mothers, and 3 had respiratory symptoms in the first days of life, and they were tested positive on day 2 after the childbirth. But we don't know the transmission route. It could be that these children were affected after birth. The only serious ill neonate we found in this case series was a preterm infant with 31 weeks gestational age. So we don't know whether that was affected by anyway in COVID or other reasons. Next. So until now, let me be very clear, until now, breast milk samples were found negative for COVID-19 virus. And these are the publications. Now they're not hundreds of samples done. Breast milk sampling is not that easy, and also not the testing, but this is for so far, there is no breast milk sample found positive. Next, please. So various research projects are now going to start in various locations. I know myself because I've been involved in a few. So they're looking at pregnancy, the delivery, postpartum transmission, and also samples for breast milk will be looked at, including colostrum, amniotic fluid, feces, umbilical cord, etc., etc. Now, we also hope, and I'm trying to push for that, that this research will look at effects of skin-to-skin contact, whether that also will be a mode of transmission. And I will also hope that the breast milk samples are not only in the first week taken, but over a certain period of time, because like with Ebola, we still don't know whether the virus stays, when the virus appears in breast milk. As you know, that the mammary gland is an immunoprotective site, and therefore anything what is in there will come out perhaps later. So I hope that the research will take that into account and not only take samples in the first week. Next, please. So what are the recommendations? Well, in December 2020, we had no recommendations at all. And to date, there are many. And they're all variations on the same theme. Next, please. Now, all these guidance materials that are produced at the moment are some are country specific, some are mandate specific and look at specific groups. Some are context specific, whether it's resource or cultural specific, but also a lot of these guidance materials have different target groups. Some aim for healthcare workers, some more at parents, some more at professional groups, whether it's neonatologists or others. So there's a lot out there now. There's also a lot of repetition, but the good thing, there is a lot, but they do divert. Next, please. So to date, and I will quote here very clearly, WHO's position is, and that's based on expert panel committees, etc., is that the women with COVID-19 can breastfeed if they wish to do so, and if they can, of course. And here are then the normal IPC procedures, the normal practice for infection prevention and control. Also, if you're close contact with your child, will only help to breastfeed the baby and to thrive. So a woman with COVID-19 should be supported to breastfeed safely, hold her newborn skin to skin, and share a room with her baby. So this is the WHO guidance, and I stress that is our normative agency on this. Next slide.
May I know you can't see the chats. If you can just lean closer to the microphone a little bit so people can hear you better.
Sorry.
Thank you.
Thanks to Dr. Anjali Palmquist, a colleague and friend, I borrowed her 2 slides. The WHO guidance is very clear. Suspected confirmed mothers, if they're well enough, should be supported to nurse the babies. You have to practice respiratory hygiene, and if you have masks, great. If not, alternatives possibly. Wash hands thoroughly before and after touching the baby, etc. I don't go through all the details now because this is all common sense and you know this already. I'm sure the audience knows this. Lastly, the close early contact is still recommended, so skin to skin should be supported along with respiratory and hand hygiene for all caregivers and helpers. Next, please. So the suspected and confirmed mothers who are too sick to care for their baby, but wish for their baby to receive their own milk or donor milk can do so. And it can have support to express breast milk and support with relactations, etc., etc. Okay, next, please. Now, we have a group, and it's coordinated by the WHO and UNICEF and WFP and UNHCR and Johns Hopkins and a little bit of CDC and ENN, Save the Children and MSF are all part of that. We're looking at a decision tree and it's under construction. I hope it will come out soon. I hope within a week or so. The wording is not definite yet, but if a mother is unable, so too sick or unwilling for some reason to provide breast milk, then indeed use of breast milk substitute could be recommended. But what I said, the wording has to be confirmed. Next, please. So some of the guidance materials, what is around there, it seems that the focus is mostly on the risk of disease transmission rather than aiming to focus on the benefits of breast milk, that the risks of not receiving breast milk and therefore exposure to the risk of use of breast milk substitutes are not so much highlighted in a lot of the guidance materials. And I think that's not a good thing. Also, the risks of no skin-to-skin contact or the mother and infant separation. We found some of the guidance that says separate the children in the first 14 days, as demonstrated here on the right-hand side. There are many risks of this, and we still have to figure out whether that's the right response or not. So far, the evidence in science doesn't support the situation. Next, please.
Excuse me again, Maya, before you go on. There's somebody who is writing on the screen. If I can ask you to delete it and to not do any more, that would be much appreciated. Thank you. Back over to you, Maya.
Okay, so this is my almost last slide. What is still not clear? There's a lot still not clear. whether the skin-to-skin contact is a mode of transmission. Is there a risk of transmission? Is there can the virus be inactivated by certain heat, by certain handling of the virus, or cold? Are there safe alternatives to masks? Can the virus appear in breast milk weeks or many weeks later after a mother with COVID has recovered? Can an infant actually infect a mother? And what are safe ways of disinfecting your mask or the alternatives of them? We still don't know have evidence on what programs are the best. Are there don'ts and do nots? There are do's and don'ts. And then many, many more questions. Last slide. I just want to tell you that following the research now, we will at Hopkins provide a website where we update for every 3 to 4 days the new evidence that comes out related to this subject, so that as soon we know more, people can be informed and take decisions. The number of research articles coming up is like exponential, almost like the virus and the pandemic itself. So we will hope to keep you updated with evidence. Okay, that's all. Thank you.
Wonderful. Thank you so much, Maya. That was very interesting. I'm sure everyone will agree, and I do see questions coming for more information in the chat box. All those questions, please do keep on writing. Any inputs, questions, clarifications into the chat box. We will handle them at the end of the presentations. Now I'd like to go over to Ashima Garg from UNICEF to give us a brief on the recent brief that has been put out there. In the meantime, Ben is going to re-share the slides so that we hopefully don't have the markup on them. And yes, there's a question about whether the slides will be shared. All the resources will be shared after the webinars. They will be available also on the Tech RRT website. Wonderful. Thank you, Ashima. Over to you now.
Thank you very much. And I do see some of the questions, colleagues, around complementary feeding. I will try to address some, but building on this strong understanding of where we are with the evidence so far. So in next 10 minutes, I will focus more on the programmatic direction and take you through the recent brief which was launched last week. Next, please. Can I have next slide, please, Ben? Thank you. So so far we have seen from the previous presentation that the evidence-informed recommendation for us is mothers with suspected or confirmed COVID-19 and isolated at home or in a health facility should be advised to continue recommended infant and young child feeding practices with necessary hygiene precautions. Next slide, please. So just to zoom in, when we say recommended IYCF practices, we know all the recommended IYCF practices stand as they are in the context of necessary hygiene precautions, with Mia just highlighted on hand washing with soap at critical times, routinely cleaning the surfaces around the home, using face mask or alternative options, and maintaining physical distance. Next. So I will start my presentation with a focus more on how can we translate what we know from evidence into informing or adapting our programs. So one thing which is clear is programs and services to protect, promote, and support IYCF practices should remain a critical component of our programming and response for young children in the context of COVID. When we say it should, we need to reflect on what adjustments do we need to do. And in next few minutes, I'm going to focus more on the how part of it. Next, please. So few minutes on this before we think about how do we adapt our programs to this context. We need to spend or have some moments to think about understanding what is the programming context. What has changed between December and now in our programming? we need to take stock in terms of understanding what could be some of the gaps, bottlenecks, and barriers. One of the major reality which has come as part of this context is reduced mobility due to lockdowns, which has led to limited availability and access to services and nutritious and healthy food choices, especially fresh produce. When we think about our families, mothers, and caregivers having information and advice they need in this time, there is anxiety, there is uncertainty, there is too much happening through social media, but there is no contact. So what is the status of information which families are receiving on what, when, and how to feed their infants and young children? Is it limited in our context? Is it not available? Are there any misinformation which are coming? So we need to take a stock on that. When we look at what's happening at the policy or the enabling environment level, we also need to understand and take a stock of if the emergency preparedness and response plans for nutrition and related sectors are focusing on reaching on infants and young children in this context. There has to be an effort to understand that. We also need to take a stock and understand when we talk about different delivery systems, health systems, food systems, WASH, and social protection, to what extent are these systems able to deliver? We talk about health facility or institution-based service delivery is impacted. We talk about the community outreach is impacted. So what are the alternative options of delivering these services? And it may vary from country to country and region to region. So what is feasible in our context? We need to also take a stock of if the adherence to International Code of Marketing of Breast Milk Substitute and other WHO resolutions, as well as issues around donations and marketing and promotion of unhealthy foods, is it happening in our context? What are the different checkpoints we need to fix to make sure that this is not happening? Also having an understanding of who the stakeholders are in this arena who are responding. Is the response coordinated? Are we building on maximizing on the comparative advantage for each of the stakeholders which are there? And on top of everything, we need to remind ourselves to look at the status of malnutrition in our context, because no doubt to say that malnutrition, high malnutrition rates will predispose infants and young children to higher risk of disease and malnutrition in this context. There can be many more things which we should look at, but I listed down the key ones. Before we go in adapting our programs, we need to be careful to spend time in understanding the context. Next, please. So this is just to highlight that when we start looking at what to do and how to do, there are a set of guidance, a global guidance available. Mia just highlighted. I've highlighted the 4 guidance, IFE Core Group, WHO guidance. We have IASC guidance on distribution and the complementary feeding guidance from UNICEF. Next, please. What we did was, taking into consideration all the different guidance documents available, we put together a brief which was released last week, which is a programmatic brief which consolidates the recommendation on infant and young child feeding in the context of COVID, and it suggests key considerations for operationalization of recommendations. As Mia said, we don't have all the answers, and especially as we are going towards programmatic side, we don't have answers and we are learning as we go. So next, please. What I'm going to do in next slides is to give you the flavor of what this brief is highlighting. It's an 8-pager brief. I would encourage everyone to please have a read through it. And if you have questions, please, we will have a mechanism through which we can further provide support. The first point to reflect is, where are we delivering services, as a lot of families and mothers and caregivers are at home. So at home, when we think about delivering services, we need to think about how can we continue to support families on what, when, and how the children are being fed. Okay. Could you please mute your microphone? And so the support needs to be provided on what, when, and how to feed the young children, but also to promote safe hygiene behaviors. And all this, we need different platforms need to be explored and found out what is most suited in this context to make sure we are able to provide simple, practical, and context-specific information using the available channels. One thing which I would like to highlight here, which is coming to our notice, is with the limited access to fresh produce and staples, and because of the lockdown, there is a high risk of families choosing to go on feeding unhealthy food options for infant and young children. And that's something which we need to figure out in our messaging, in our the communication which we do of how healthy feeding options for young children can be promoted, and also mothers and families could be advised. Next. At the enabling environment level, as I mentioned, the focus needs to be, we need to take a stock and influence the alignment and coordination in the mitigation plans across nutrition and other sectors. Also alignment with the International Code of Marketing of Breast Milk Substitutes and subsequent World Health Assembly resolutions. We all know, based on our experience, this can be a major area where the breach happens, and also making sure that the donations of BMS, complementary foods and feeding equipment is not sought or accepted. Next, please. So briefly on delivery through different systems. The brief goes into details about all these 4 systems and different considerations. But one thing which is sure is that we want to make sure that actions through each of these systems prioritize the delivery of preventive services to mitigate the impact of this pandemic on young children's diets, and also have strong linkages with early detection and treatment to maintain the continuum as we always talk. Next, please. When we talk about the delivering through food systems, the focus, or we have to talk about how can we maintain access to fresh foods and essential staples? How can the guidance be continued for community and families on healthy food purchase? Also looking at the control and marketing and promotion of mass distribution, donation of unhealthy food, and how can we positively influence the way the in-kind and financial contributions do not violate what we have said as should be done. This is a major area which needs to be looked at. Next, please. When delivering through health systems at health facility, as Mia highlighted, the protocols, the evidence, we need to make sure that we establish safe breastfeeding protocols, and mothers and infants should be provided with skilled breastfeeding support. When delivering services through facility, community, and remote platforms, we need to ensure that IYCF counseling together with psychosocial support and practical infant feeding support should be provided to infants, to mothers and mothers with pregnant women and mothers with infants and young children. Next, please. Through WASH systems, when we talk about, WASH is integrated in multiple levels, and across this emergency, we have realized the importance and reinforcement through WASH. But there has to be a continuous process when we are delivering nutrition services and other services through system. How can we intensify the integration of messages on safe hygiene practices for infant and young children using innovative communication channels? We have to look for different options depending on what is feasible in the country. Like if there are operational service delivery, how do we integrate? If it is not operational service delivery, how can we use virtual channels to integrate these messaging? And making sure that the messages on WASH, which we have, are harmonized across multiple communication channels so that we maintain the same message. Next, please. Through social protection systems, they have a huge role in influencing or kind of making sure that we improve the access to nutritious, healthy food choices, coupled with nutrition counseling. However, in this scenario, we do understand that the routine programming is not happening, and with the limited contact and mobility, it may be difficult to maintain the delivery of services. And however, it has to be taken into consideration wherever the social protection programs are functional or working. we avoid the provision of unhealthy food as part of alternative arrangements. So there may be cases where we have feasibility of running the social protection programs through alternative arrangements, but we need to make sure what goes as part of the provision to improve the access, we make sure that the unhealthy foods are not included as part of this arrangements, and we need to be careful in establishing partnership with food and beverage companies that produce unhealthy food so that we maintain the social protection services and platforms with the core purpose they are designed. That's the last slide, I think. This is just a flavor of what is there in the brief and our efforts to streamline and provide some thoughts on how can you go forward. And I know Alex is going to cover more around the delivery platforms, and we can take more questions as we go along. Thank you.
Thank you so much, Ashima. Very informative and useful to be able to highlight the key components and important aspects of the brief that came out on last Monday. Okay, we're a little bit behind on time. I would like to go now to Jodine Chase from SafelyFed Canada. Over to you now, Jodine. Jodine, you're still on mute. Ben, can you please unmute Jodine?
Okay,
there we go. And I see we do have somebody else that their video is on. Please, if you can shut your video off, that would be much appreciated for those with poor internet connections.
You can go ahead to the next slide, please, Ben. So I'm going to zip through a little bit of very basic information about communications support for this crisis. I'm using as the guidance the US Center for Disease Control's CERC model, Crisis and Emergency Risk Communications. And just briefly, I'll give you a quick overview of that model and encourage you to make your way to that website for some excellent tools. So there are 6 principles for communications in a crisis and emergency, and that is to be first, to be right, to be credible, and to express empathy in your communications, to promote reasonable and feasible action, and to be respectful in communications. Next slide, please. There is a good document that was just updated last year, which helps us to understand the psychology that is behind the communications methods that we use in a crisis. And I encourage you to take a peek at that as well. The key points that I would like to focus on today are, of course, we're thinking, what do people need to know? What messages do we need to send out about infant and young child feeding during this crisis? And what we need to think about also are what the psychological barriers there are to keeping people from hearing the messages that we are communicating. So in a crisis, because people are confused, because they are afraid, because the emotional response is keeping their logical brain from working as well as it usually does, and they have cognitive overload, people take in and process and act on information differently. Next slide, please. So there are 4 ways that we process information in a crisis. And this document that I'm sharing from CERC is actually an excellent example of how to simplify information. So first of all, as humans, when we hear information that is new and could be complicated, we misunderstand and we simplify messages. We don't fully hear, we can't process all of the facts that are coming to us at the same time, and we have less ability to remember or to store that in our short-term memory and convert it to long-term memory. And so the solution for that as communicators is to use plain language and to use simple messages. Next slide, please. We hold on to our current beliefs. Those are things that we know and understand. And so contrary messaging, something that contradicts our current understanding, is rejected. We also interpret information based on our current beliefs, our existing beliefs. We pay attention to what is consistent with what we believe. So in a hurricane, for example, if the message is to evacuate to a safe place, we may interpret that as my house is safe. And so we may not necessarily process the need to evacuate, that my house may not be safe in a hurricane. And so messages need to come from credible sources. We need to be able to trust the information that we are hearing, especially if it contradicts our current beliefs. Next slide, please. So we look for additional information and opinions, especially when we are hearing something that is new or when it contradicts what we believe. And you will all recognize that when you first become aware of some new and striking information, you may be so surprised, you may switch the television channel over to another channel to see if other stations are saying the same thing. We also check in with our friends, with our peers, with family, and with trusted sources. And so for communicators, we need to be consistent in our messaging, understanding that people are going to be looking for different sources of information to confirm the messaging that they have received. Next slide, please. And so another way, the fourth way that we process in a crisis is we believe the first message that we hear, especially if it's new information that we have never heard or understood before. And then when additional information comes in, we compare that to the first message that we heard. And we either affirm that first message or we may discard the subsequent messaging if we don't have time to understand and process that the new message is important. And this is why one of the main principles is to be fast. And it's important then for us to release accurate information and to release it quickly, but also to repeat information and to use multiple credible sources for information. Next slide, please. So I'm going to talk now a little bit about some do's and don'ts in messaging. One recent affirmed information that we have around messaging that comes out of the literature is that presenting myths, inaccurate messages, and then countering them with facts can be less effective, especially in a crisis. What can happen is that people may actually process the myth, and that may become their truth. And so what we encourage is for people to be specific about their messaging and to use a learn more technique. So for example, we wouldn't say some people believe that your milk dries up in a crisis once you stop breastfeeding, your milk dries up and you can no longer breastfeed. We would simply state the fact. You can relactate and then offer people the opportunity to learn more. We also want people to be able to see information in short chunks that they can process. So chunking is important, short, simple messages. And then, and this example on the slide is a social media example, but this works very well also with posters or other types of information where you can direct people to additional information. So a poster on the wall with a simple message, and then learn more, and you might have that in a handout or a brochure. You want to layer information, so people don't need to necessarily seek out the details. They first just simply are exposed to the short, brief information like that poster, or the social media example, which is on the left. The text on the right is actually in the caption, so they don't see that right away. People need to hear very specific information to this particular crisis, and the information needs to be targeted to their particular circumstances once you get the basic information out there. So you want to offer people the opportunity to take action and give them positive and realistic courses of action. Next slide, please. Some additional do's and don'ts. When you're communicating, you want to communicate the behavior that you're seeking. You want the behavior to, the communication to reflect the behavior that you want. So this is an example from some information in Canada, and of course information is being presented now all over the globe. But this is very simple images on the top right of that handout and that poster that is on websites as well. So we want people to breastfeed, and if we want breastfeeding, we're going to show breastfeeding in our images. We don't want to normalize the behavior that we're seeking to avoid. So if we're communicating that we would like people who can't breastfeed to express milk and use a cup or a spoon, then we don't want to use images of bottles. We want to show cups or spoons. Now there I've just violated the first rule. I told you what not to do instead of telling you what to do. Next slide, please. The last two slides are specific to determining audience. And this is, it's important, I think, for us to acknowledge that this is a really complex situation, and we are in a complex world. This is a complex emergency. And so our audiences, we have many different audiences that we're going to communicate to. There is some simple and consistent messaging that we may communicate across all of those audiences. So the importance of starting breastfeeding, the importance of continuing to breastfeed. But we need detailed messaging, simple messages, as well as detailed messages for different audiences that are specific to each of our local circumstances. So I have messaging that we've prepared for folks in Canada, which is a high-income country, but of course the circumstances in other places are going to be very different, and the message needs to be targeted to the specific circumstances. We need to make sure that we're identifying the audience that we're communicating to. Next slide, please. And so you'll see in this next slide, if you're going to communicate, if you need to communicate to late-term pregnant women about general advice and maybe also specific advice to your local community, perhaps the location where they're going to birth has changed, target that message specifically to those people. Make sure that your message that is targeted to those who have just birthed with newborns, let them know that you're talking to them. I'm talking to you, family with a newborn. If you're messaging for people who are not breastfeeding, if you want to communicate around formula feeding, be very specific and say, this message is for formula feeding families. Be direct. If you have direct information that you want people to take action on, tell them what you want them to do and give them detailed information after you've got their attention with those key primary messages. And consider the why. That's the respectful part of communication. People need to know why you're telling them to do what they want to do. Be respectful and assume that they have positive intent towards their child and love towards their child, and they're going to do everything they can, including listening with good, close intent to your detailed messages about what it is that they need to do. So that is my snapshot of communicating during this time, and I'm going to wrap it up now because I know we're short on time.
Thank you so much, Jodine. That was really useful, very practical messages for us to be able to program by. As we are a little bit behind, I'm going to hand over quickly to Alessandro Ialamo from Save the Children. Over to you, Alex.
Thanks, Sandy, and thanks to all my colleagues and to all of those that are connected to this webinar. So yes, I'm going to share some pragmatic experiences and ideas in relation to, so how do we continue, no? How do we continue protect, promote, and support infantile feeding in the context of COVID? And I will try to provide some of those details to the initial framework that was presented by Ashima, supported by the evidence that Mia illustrated. Next, please. So there will be two main objectives. One is we will all try to identify concrete adaptations of IYCF interventions, and also understand what are the potential platforms that maybe some of us have already used, maybe we haven't used, maybe we knew about, but we didn't try, or we didn't scale up in our own context. Next, please. Let's start from our current programming, and I identified, and you can, from what you can see from the slide, some of the most common interventions that we support both in humanitarian and in non-humanitarian contexts. So we look at counseling, support groups, as well as support groups, care groups, and group education. So based on our conversations, now our office and other agency, we do know what are the fears and concerns. And some of you have expressed those fears and concerns in the chat box. Well, what is important to say that based on the evidence we have and based on the recommendations we have, we do have some ways that can help us adapt, for example, counseling. It is recommended, and if we follow the respiratory and hygiene protection measures, trained counselor can continue, should be able to continue, provide those services at least to the priority to those that have special needs and requirements. When we look at community-based activities, this is where usually we do have more concerns in line with social distancing and avoiding or preventing contacts. So there are ways, and we have heard from some colleagues in the field, wherein we can try in line and fulfilling those social distancing rules, where messages can still be disseminated within the community, by the community themselves. Next. But again, if I wanted to switch and I wanted to focus on other platforms, and this is a very short presentation, it's more to help us think and reflect on what can work in our context. Next, please. So let's look at what has worked, and I'm going to propose or promote platforms that by evidence have worked in certain contexts. So let's look, for example, the use of cell phones and SMS, text messages. So in this study that was conducted in Mexico, for example, it has shown that weekly counseling through cell phones for those mothers with specific problems and recurrent, for example, SMS messages have indeed improved breastfeeding indicators, So that's just an example where in a certain context where obviously access to cell phones and coverage was ensured, this methodology has worked, Next. Let's also look at a combined effort wherein a trained health worker combined with recurrent radio messages, the same messages, one delivered by an individual, the second emphasized by the radio, again, in a combined effort, have shown a major impact in improving significantly the infant and young child feeding attitudes and intentions, but it didn't show any impact actually on the social norms. But again, it's important to emphasize one thing in this case, how both the message of the trained staff or the trained counselor, in this case a nurse, and the message given by the radio were actually the same messages. So there was a continuous exposure by the caregiver, and also a sort of reaffirmation between what the trained staff and the radio was actually proposing. Next, please. Let's look at in contexts and environments that have used other form of media. So there was an important systematic reviews that identified 18 studies where different form of social media, printed media were used, have been used to promote, to increase, to contribute to the increase of infant and young child feeding practices in different contexts. So interestingly, 15 of the 18 studies confirmed that this use of media, social media, radio, cell phone, calls, SMS, indeed helped improve breastfeeding and complementary feeding. The only concern that was raised by this systematic review that no one of them did it in a standardized way. So basically there were different ways of using those common tools. Next. And obviously, let's look at contexts where, and there are many countries, even low-income, middle-low-income countries, where social media is extremely popular, even among the urban poor, of the rural poor, wherever there is access to internet. So there has been studies that look at how social, online social support has been documented as successful. So for example, in this particular study, they have seen that social support groups were created that were accessed by pregnant women, by women with young children, and most of the conversations were really about sharing concerns about infant feeding and trying to address, so try to access information on how to address their own concerns. So this was a study that, it's a study that shows that in contexts where social media is used in different ways and sometimes also in the wrong ways, but this could be a tool that if properly facilitated and supported may help reach out to entire populations with the correct information and help them address their issues and concerns. Next, please. Lastly, there was also this study about Instagram that, as you all know, it's very much based on images and conversations that confirm more or less the same line, the same results of the Facebook-based social support groups, no? And confirm that in this particular context, the users were actually displaying and sharing the diverse questions and images around breastfeeding among their supportive networks. Next. So, and again, this is just was just an initial set of suggestions to make us reflect. No, one and foremost is we can adapt our existing activities so that programming will continue. Also, in case we didn't use any of those platforms, either cell phone, etc., then we have also some evidence that they may work, no? That they may work with the necessary adjustments in the context where we are. Next. But always let's remember, and in a way, Jodine mentioned it, that to be successful, we need to think about the exposure that our women, our communities have on those, for example, infant and young child feeding messages. So the frequency, how much of that message is being received. And also it's very important, the evidence has shown that it's a combination of those methodologies, those modalities that makes impact, that makes it more impactful. Next. And obviously in low literacy environments, visual images, pictorials are the most effective, the most accessible. And lastly, but not the least, integration. We are not just saying that infant and young child feeding messages should be, for example, disseminated through or by health workers, but there are other platforms, other mechanisms in our other sectors that can be perfect in a COVID-19 context as messenger, no, as carrier of our message. But at the same time, when you look at providing support, even if remote, through phone counseling, for example, obviously that's required a skilled, no, and trained messenger and trained counselor. Additional to this slide, sorry, I didn't have the time to add is, this is maybe the time we can think to collectivize our platform. So I encourage agencies not just to think of an agency solution, but this can be, if I devise a platform for SMS sharing or phone counseling, maybe this is the chance for us to synergize, pool resources so that when I deal with a network company, for example, that could benefit not just my project area, but all the geographical area where that network is present. Next. Thanks. So I think the main message for now is really we can continue, we should continue. The evidence recommend us the way on how we can do it safely. Our mother can continue breastfeeding and support their infant feeding practices. But we also have to find a way for our programs to keep reaching out to the largest possible population in the way that Jodine suggested, but also ensuring that really no myths and miscommunication or misunderstandings are being spread during this COVID-19 pandemic. And I'll stop here. Thank you so much.
Thank you so much, Alex. That was very interesting and enlightening and gives us a lot of a little seed in our brain to start thinking about how can we reach those populations in the way that's most accessible for vulnerable people on the ground, potentially in rural communities, etc. On that note, we are behind, so I'm going to quickly wrap up to go to the Q&A session. Linda Shaker-Barberi is going to lead us through that. Over to you, Linda. Oh, we are trying to unmute her. She'll be with us in just a second.
Hello.
There you go. Thanks, Linda. Over to you.
Yeah, can you hear me? Okay, great. So thank you everyone for the very interesting presentations. And I can tell you, and you can see on the chat box, there are lots of questions. So what I'm trying to do is try to categorize them and really go through some of the main themes of the questions. I will start first with some of the basic questions on Mia's presentation. One of the questions was, what about inflammatory response in malnourished children? Children have usually been vaccinated more recently than adults. Could that be one of the reasons they are less affected? I think that's for Mia to answer, or
okay.
Anyone else?
We don't know. It's very simple. Whatever I've seen, what is actually researched at the moment, I don't think malnourished children have been greatly researched yet, so I don't know. Sorry.
Mm-hmm. Thank you, Mia. The other question is particularly mainly about breastfeeding initiation and skin to skin. Question about the early initiation of breastfeeding. What is the recommendation around that? And also around skin to skin care by family members. I know you mentioned, Mia, that there are issues with the skin to skin. Also, there's one person who has actually is asking for ideas on how to persuade neonatology team that the mother-infant close contact is important, and that many units are not allowing any contact with infants in the NICU. So, and I think this is not the first time we hear this. Mia? Mia?
Everyone, just bear with us for just a second. All the presenters, can you please put your videos on and your mics, leave them on because they automatically will stay locked off if you don't.
Okay, sorry. Yeah, the neonatologists, I don't think we have to, I think first of all, my message is follow WHO guidelines. There is a newsroom, there is question and answers there, and it's well formulated. In that, it states early initiation of breastfeeding is recommended in the COVID context. So I would closely follow that website, and it's up to date. So if there are changes, then you will find changes on the World Health Organization's website on this. Whether neonatologists are not convinced that close contact, skin to skin, is important, that is beyond COVID. That is an issue that is all encompassing anyway. So I think we all know that skin-to-skin contact is important for regulating the temperature of the child through the initiation for breastfeeding, hormonal response, emotional bonding, etc. So that is not specific, say, for COVID. So that would be still very important to convince neonatologists of that, regardless of COVID. Family members, I will just issue that whoever handles an infant, whether it's the mother or a healthcare worker or a family member, there is a risk of exposure to COVID, and it has to be, the normal hygiene procedures have to be followed. And people are asking about masks or alternatives. At the moment, some of the people have ideas to perhaps, if you breastfeed, cover the infant perhaps with a cloth. So if you cough or whatever, that there is less risk that the child inhales that. So these are some of the other recommendations.
Thank you, Mia. The other recurrent question is about face masks and whether there are any concrete guidance on their use, which face masks are recommended, any guidance on homemade masks, and yeah, basically this is it.
Okay, I couldn't unmute, so be careful because I can't unmute myself. So face mask, there's a lot written about face masks at the moment, and I think there will be alternatives also described on the WHO website. I cannot say one alternative or the other is better. So as there are so many guidelines, just go to the site you trust most, like for normative agencies. That's all what I can say. And look what your government, your Ministry of Health is saying about this issue. I'm not in a position to give a global advice on that, but follow either WHO, follow UNICEF or your Ministry of Health guidance.
Thank you, Mia. A couple of questions around expressed milk and milk sharing and wet nursing. Whether COVID tests should be done routinely for all mothers wishing to donate milk or in the context of human milk banks. Why is donated milk not mentioned before formula in line with WHO guidance? Will you recommend wet nursing in a situation where a mother with COVID-19 is too weak to breastfeed? And yep, this is mainly it. So milk sharing and wet nursing.
Maybe Alex, you want to say something, or anyone else at the forum? The only things I can say about the sampling, I will answer that question, is for now, breast milk has not been found having the virus. So that's all I can say for now. So whether you should sample or you should actually test first a breast milk sample from a donor, I would say donor milk has to be safe. So that would be a good advice to test any milk before giving as a donor. But as it hasn't been found yet, one thing, I'm not sure whether that's helpful now. Secondly, the testing is still in many countries behind, and breast milk sampling and the testing are not so easy either, because there's easily let's say cross-contamination of the sample. So it is not so easy to do. I think follow HIV guidelines on human donor milk as well, how it's done with other diseases. Maybe anyone else of the panel. I'm not an expert in donor and milk.
No, just to add, Mia, you are very right. I think WHO for now confirmed donors' breast milk as an option when breastfeeding is not possible, notwithstanding the hygiene and respiratory protection. But donor breast milk following the standard recommendations. And for wet nursing, it's also part of the global recommendations. Obviously, it again follows not just the standards and the recommendations, but also follows the cultural acceptability in general, no? Of the action. So for now, we have these global recommendations, but please use your local, national, existing specific guidance, not in line with what Mia just said.
Thank you. The other list of, actually there's one question related to breast milk substitutes, and specifically what can we recommend in the case of providing breast milk substitutes in the context of lack of clean water, limited knowledge and preparation. Is ready to use BMS an option? And I guess we do have the answer for that. Alex, maybe?
Sorry, can you repeat? My line is not.
Yeah, so it's a question about breast milk substitutes and what are the recommendations in case it's necessary to give breast milk substitutes in the context of lack of clean water. And actually, clean water is something that has been mentioned by more than one person on the chat box, lack of access to clean water.
Yeah, no, well, and again, we don't have specific recommendation in a for COVID-19. So if I'm not mistaken, Ashman earlier shared some of the existing and current recommendations. So for example, the IFE, the Infant and Young Child Feeding in Emergency Operational Guidance, does provide for a clear criteria on when to use, for example, ready-to-use infant formula versus powderized infant formula. So we still have the same recommendation, the same criteria. The use of one or the other should be done according to a specific context analysis, resource analysis, obviously having a clear criteria in place. So again, it's nothing really specific to COVID-19, but follow those existing pre-COVID-19, let me say, standards also in this case. Over.
Thank you, Alex. Thank you. So there is a list of questions around remote support and some of the challenges. One of them is to reach people who do not have cell phones or internet. Also the need to monitor, worrying about the need to monitor the information that is disseminated and the capacity that is needed for the people administering the messaging. And the last one is about illiteracy. What about in the context where families are illiterate, caregivers and mothers? Who would like to answer this question?
Would you like me to answer it, Linda, from a more of a communications perspective? So
sure, please,
I
Michelle.
think in a context where there's limited access to new media like social media or televisions, those communities will have pre-existing methods of communicating. So often those are places where radio works well. But even in those conditions, people may be accessing the radio in public spaces, like in stores or in public gathering places. So we'll need to think about how many of them are able to access radio even just at home. The other piece that may be useful in those settings where there's very little media is, I think in Alex's slides, he talked about the visiting a neighbor kind of way of doing things. So that may be one method for community health workers to identify sort of champions within their communities that can share those messages. In terms of maintaining messaging that's consistent, even when we don't have eyes necessarily on how those messages are delivered. I think Peggy was one of the people who mentioned that, and that's always one of the concerns that we have when we're sending the message out into the world. We don't get to control how it's going to work. What I would suggest is that's where keeping the messages very simple, very replicable. So if anyone's ever played Broken Telephone, the game where you pass a message from ear to ear whispered across, the simpler the message, the more likely it is to make sense at the end of your telephone change. So really that's where doing our work at the beginning to make sure that the messages are simple, they're clear, and they're not easily distorted is really critical. And then what was the last question? There were 3 pieces to that.
Yeah, there was the capacity of whoever is managing the platform, and also the monitoring of the platform.
Yeah, so I think the monitoring piece is really around making sure. So if you have online monitoring, you need facilitation skills to help keep people on track, and have individuals within that group who can provide accurate evidence-based information and access to resources. And then on the capacity side, this is one of the challenges that we have in communities where we don't have a lot of pre-existing capacity. But I think that focusing on really simple, straightforward messages and facilitation skills, that's something that we can scale up fairly rapidly. So I think the front end work of producing the messages that in a clear way, in a way that's acceptable and understandable by the communities is really the key work. And that's work that we can do up front, so that when it gets passed into the communities, it's most likely to be replicated accurately.
I think if I could just add as well, one of the gaps that we see is that there are communications teams working to communicate general information out across populations, and they often aren't considering infant and young child feeding in emergencies as something that is important for them to communicate. So this is an example really of how cross-cutting our work is, and we may not have the connections to those other crisis communications teams. But if we can develop really simple messages in advance and then reach out to those teams with some very basic information, the numbers of birthing families over the next week that need to hear this information, typically then they will respond, and they can plug your information into their existing ways of communication, and even perhaps just looking to see at what methods they're using to communicate. It may be that in your experience, this is all harmonized and you're all working together. I expect, though, that that's not the case in a lot of communities, and there are some general public messaging efforts going on that we should be finding and tapping into.
Yeah, and maybe, sorry, because I saw that this has been, it's an importance particular. UNICEF just started, and it will be a very efficient process, leading the adaptation and development of those standard messages that Jodine mentioned, but just short messages and enrich basically visuals and images for low literacy communities that will eventually be disseminated and distributed across the different contexts. And again, if Ashima wants to add more, but that's a piece of work that eventually will support what just Jodine has recommended. But let me say again, I call on all of us. No? Today we were more than 500 people. This is the time to build that partnership on the ground so that those messages are one for all, are common to all, are standard to all at the ground level. And those platforms, those mechanisms can be shared among partners so that, again, we we have one common goal, is reaching all the communities and everyone in the community with our existing infrastructures with the right information. So I don't know, Ashima, would you like to add something on this initiative you're leading?
Thanks, Alice. Just to add that the intention to keep it efficient also and not to come up with a lot of new tools, what we are doing is building on the existing images and messages which are part of the IYCF community counseling cards. So what we have done is we are working with the same group and designers who developed those cards and adapting it to make the cards applicable to the current context of COVID. So that's why we are saying that this is going to be a very efficient process with real adaptation. So watch out, we should be coming out with it soon, within a week or so. That's our intent. Thank you.
Thank you. That's really wonderful and really looking forward to seeing the whole product. There are a couple of questions about food distribution and access to food, and specifically in refugee situations. So in refugee situations, how to ensure food distribution is organized safely. Also in the context of social distancing, access to food is hard. And also in terms of providing messages with the food distribution or door-to-door messages through flyers, etc. What is our take on that?
I can just mention here, Linda. Yeah.
Yep.
Yeah.
Please.
Can I go ahead?
Yep, please.
Yeah, so just to mention briefly, there are the guidelines, interim guidelines by IASE led by WFP, which are available on food distribution. I included it on my slide, but we can share the link with people as part of the resource. It does provide some guidance on organizing where it is feasible to organize food distribution and all the guidelines around it. In terms of identifying the options for what could be the foods and the medium, again, as we have been saying, as we have to see what works in that context, what's working. Once you know, are the flyers working? Is that the way to, do you have a mechanism where you can distribute the flyers, or it's a combination of key messaging? So my take would be, when the access to food is limited, try to see what is working. It's like, do we have access to canned products, tinned products, or the products which are available? Then the focus should be on information on what kind of food should be available or taken to the family. But at the same time, if we have some access to fresh produce, we should then work on making sure that how that fresh produce can get to the family. So it's more of, there's no one answer for, which is like, just do this. It's like we have to figure out, and we don't have very direct answers, just have experiences from different places. I don't know if anyone else on the panel wants to add. Over, Linda.
Alex, thank you so much. Ashima, anyone else, Alex or Jodine or Michelle, want to add anything to that? Or Mia?
No, I just to say, I fully agree with Ashima. It's, let's look at what works in that context. But maybe this is just an encouragement. This is the time again to be as creative as we can.
Yeah. Thank you, Alex. And also along the lines of food, there are a few questions about micronutrients, evidence on zinc supplementation and COVID-19 incidents, specific micronutrient needs to be part of the children's food, and also related to vitamin C, anything related to that. And I'm just going to continue since this is also related. So not only nutrition for children, but also maternal nutrition, dietary diversity for mothers and children. Do we have like specific guidance on that? And one last one about maternal health and nutrition. Given the links between poor maternal mental health status and child nutrition and growth, what could be done to better support mothers who are stressed? I think this is separate, so we can maybe address child nutrition recommendations and maternal nutrition first, and then go to mental health.
I can start and then others can end. Yeah. So to my knowledge, I'm not aware about any specific evidence, and Mia, Alex, and others, please feel free to add on having specific evidence regarding zinc and COVID context, or specific types of food and their protective effect, or the linkages of, so we don't have very specific evidence, and that is what the recommendation is. We know what's healthy. What do we mean by a nutritious diet for a child in this age group? What we need to do is to find local solutions of how we can translate the food groups into what is available in that context, which we do in general. I mean, that's the message for IYCF programming when it comes to dietary diversity of women and children. So I would say that message is not different. It's just that making it applicable to what is available, linking it to the previous question, which was there, what is available, and then provide some local solutions. And as Alex is saying, through creative ways of communicating, you say, okay, we know that fresh produce is not available. We have access to the some of the packaged products, but in the packaged products, how can we still maintain diversity? And then find out, and then pitch it with the communication to it. So that would be my advice. Over. Anyone would like to add?
Well said.
Thank you.
Thank you so much. So this we have, I'm wary of time, and I don't think we have any more time. These are the main major themes that have emerged from your questions. There are others, of course, but the chat history will be there, and we will try to address those at a later stage. I think in the on the website, correct me if I'm wrong, Andy. So I'm just gonna thank you very much for your questions and hand it over to Andy. Thank you.
Thank you so much, Linda. Thank you so much to all of the presenters who've helped in answering the questions and input. With that, we are out of time, so I do want to wrap up, but I wanted to share with you some information. Obviously, as Linda said, not all of the questions could be answered. We will make sure that all of the questions are compiled and that we share it with the GTAM and UNICEF and the IFE Core Group to pull together the responses. Every week there's a call that addresses questions and tries to pull out what guidance needs to be developed, so that is something that will be done. So your questions and input has not gone on deaf ears, let's say. So I do hope we'll be able to share more information with you soon. This was a webinar, obviously, on infant and young child feeding in the context of COVID-19 pandemic. We hope that in 4 or 5 weeks from now, when we can collect some experiences from the field, then country experiences, we will do another webinar with that. That would be the aim. In addition, I wanted to let you guys know, everyone know, that we have another webinar coming up on Thursday at the same time. It's on child wasting programming in response and preparation to the COVID-19 pandemic, experiences from the field. It also will go through the Programmatic guidance brief that was put out a few days ago. We very much appreciate your attendance at the webinar today. Thank you so much. I want to thank all of our presenters. I'm going to leave you with one last slide now. And to show you contact details, we have an evaluation that I mentioned at the beginning for the webinar. We would greatly appreciate it if you could take just a minute. This link will be shared in the chat box now. If you can just click on it. On average, it takes people about 6 minutes to fill in, and it helps us greatly to make these webinars even more valuable for you. If you do have any more questions or want more information, right now I've put out the Tech RRT contact email address, website, and Twitter account. If you have any questions that you didn't ask today, please feel free to send them. We'll make sure that they get to the GTAM and the IFE Core Group to make sure that they get addressed. With that, I hope that everyone found this useful. We appreciate your time and dedication. And please do tune back in again on Thursday if you're interested in wasting programming. And look out for emails in 4 or 5 weeks on this. We also probably are we're trying to put together a French and Spanish version. So if you're interested in that as well, we will be sharing information as soon as we have it organized. Have a good day and good luck through all of the new territory that we're all trying to figure out how to get through. Remember, we need to promote, protect, and support breastfeeding as much as we can and help mothers to feed their children in the best way possible. Have a good day, good afternoon, good evening, depending where you are. Thank you.